Well, thanks, Brandon, for inviting me to do this. I really appreciate you guys having me here to talk about something I do all day, every day. And I tried to pick some topics that were hopefully going to be helpful for the internist. If I am off base, I apologize up front. But things that I think about would be interesting for you guys to know, things that we're going to be sending to you because we need your help on managing, and just some things to be aware of. And this is kind of a smattering. It's all over the place. So it's not going to flow directly right into one another, but we'll hit each topic one by one. So just in the way of background, inflammatory bowel disease is a group of diseases that two main ones, but there probably is a spectrum of these. And it's an overactive immune response to some environmental trigger in the genetically susceptible host. And this is a polygenetic disease with multiple environmental factors that are playing in, but at the end of the day, the patient's immune system is attacking itself and it's attacking the gut. The two main flavors that we see that most commonly are ulcerative colitis and Crohn's disease. And if you remember back from medical school or residency, you can think about the clinical presentations of these. But ulcerative colitis only involves the large intestine. It always involves the rectum, and it can extend as high up in the colon as it wants to, involving the entire colon. It's a mucosal disease, so it presents as a superficial diffuse ulceration in the colon when we look endoscopically. And we see kind of commonly pseudopolyps because of this ulceration within the mucosa. Crohn's disease, on the other hand, can involve anywhere from the mouth all the way through to the anus. It most commonly involves the terminal ileum and the colon. And it looks differently endoscopically. So you see these deep linear ulcerations. Classically, you'll see skip areas with abnormal tissue and then areas of normal tissue. And it's a transmural inflammation, and that is important because it leads to complications associated with this, which are strictures and fistulas because of that transmural involvement of the bowel wall. The incidence and prevalence is increasing worldwide. In the United States, it's about 250 per 100,000 patients, both with Crohn's and ulcerative colitis. There's a bimodal age distribution. We most classically think about this as a disease of young people, but there's a second peak kind of in the 60s, and I feel like I'm seeing more and more of that in my clinic, older patients with new onset IBD. And it generally follows a relapsing remitting course. And I tell patients, for a lot of patients, whether we put you on meds or not, you're going to have periods where you're better and periods where you're worse. It could be this kind of up and down. And the hope with medications is that we're going to get you in a period of wellness and keep you in that period of wellness. Up to 30% of colitis patients will end up having a colectomy. And if you think about this is a young person's disease, that's a significant morbidity. And with Crohn's, up to 80% will have a resection at some point within their disease course. And so how do we treat this? I know you guys have seen a lot of the medications that we use, and classically we think about this pyramid strategy where we start with our kind of safest but also lowest efficacy medications, our 5-ASAs, our budesonide, our antibiotics. And as patients are more severe, we slowly bump up the pyramid to higher, more effective therapies, but also which carries some more risk along with it. But really, in the moderate to severe disease area, which is where we're using our biologics immunomodulators, we've been a little bit hamstrung in that we've only had two mechanisms of action for the longest time, decades. And actually, it was really only one for the longest time, anti-TNFs, with Remicade being out since the 90s, but more recently the anti-integrins. So we've really only had two mechanisms, and if you fail, as a patient you fail these, you're kind of SOL because we don't have any new different mechanisms to offer. Tech is always an issue, huh? There we go. Does that work? Yep. Okay. Until recently. So in the past, really year and a half, we've had two new mechanisms that have come on board. And I want to spend a little bit of time to talk about these medicines, both just so you're aware of them, and in particular, the safety issues that surround these. So the first class of medicines is the JAK inhibitors. There's only one on the market for IBD right now called Tofacitinib or Xeljanz. It's also used for rheumatoid arthritis, so you may have heard of it before. And the JAK-STAT pathway, there's multiple JAKs, and they can dimerize in different ways to affect different signaling. But I think the really neat part about these pathways is that they are kind of the gatekeeper for multiple different pro-inflammatory cytokines. So by blocking them, you can hit multiple cytokines at one time, as opposed to an anti-TNF, which is only targeting TNF-alpha. The other class that we have is the anti-IL-12/23. This is Ustekinumab or Stelara, which has also previously been used for psoriasis. You may have seen this before. It's approved for both ulcerative colitis and Crohn's. And this is an antibody against the common P40 subunit, which is common between both IL-12 and IL-23. So it hits both of these cytokines. And in doing so, it inhibits T cell function. So looking at Tofacitinib first for ulcerative colitis, this JAK inhibitor, there was two kind of pivotal induction trials, the Octave-1 and the Octave-2. They were identical. I'm not quite sure why they decided to do two identical trials. They were both pretty big. And then a maintenance trial to look to see if this is effective. This is a oral dosing, 10 milligrams twice a day, which is a different dosing than the RA dose, which is 5 milligrams BID. So that's one important caveat. What you can see in the clinical, induction Octave-1 and 2 trials here on the left, at 8 weeks, there is a significant increase in patients in clinical remission on the 10 milligram dose. It also gives you a sense of how kind of pathetic our efficacy rates are here. This is 18% and 16%, which is statistically significant enough to get it approved by the FDA, but really kind of a little bit disappointing. But if you follow these patients out for a year and they're in the maintenance trial, you can get ranges up to 40% remission at 1 year. So it clearly does seem to be effective, and I think is a useful tool in our box these days. One of the really nice things, particularly for patients, is that it's an oral option, as opposed to all of our other anti-TNFs and anti-integrins, which are either infusions or injections that they got to kind of get poked to get. If it is effective in patients, it's rapidly effective. So this is a graph looking at patient symptoms after starting Tofacitinib, and you can see here that even after 2 weeks, there's a really significant drop in patient symptoms, which continues to drop after that. And I think really important, it seems to be effective regardless of whether or not you've been a failure to prior other therapies. And what we know in IBD is your first biologic is the golden biologic. And that's where you get your most efficacy. And if you fail that one, your efficacy seems to drop with each subsequent treatment that we try. And with this particular medicine, you can see here TNF experienced versus TNF naive, meaning these patients have never been exposed to an anti-TNF. Yeah, they have a higher rate of remission, but you still see a pretty significant induction of remission, even if you've failed an anti-TNF, which is really important. Thinking about the safety, this seems to be a really effective medication, but it comes with a fair amount of baggage. And I think this is important to know about these medicines as we move forward. But after this was 10 milligram BID dosing was approved for ulcerative colitis, there was a black box warning that came out about an increased risk of PE and death in patients on the 10 BID dose. And this comes from a post-marketing study in RA, where the purpose of this post-marketing study was to see, is there an increased risk of malignancy or cardiovascular events with Tofacitinib? And so they actually were trying to enhance their ability to see those events, and to be included in this trial, you had to have at least one cardiovascular risk factor. So it's a different subgroup than it is with a kind of our broader population of patients. And in this, the interim analysis showed that there was an increased risk of mortality and PE on the patients in this trial who were on the 10 BID dosing. What if you take a step back and say, does this persist if you don't have a subgroup of patients who are at increased cardiovascular risk at the outset? And so the data that we have kind of most long-term is from the RA literature. This is out to 9.5 years in RA. And you can see that really the rates of DVT and PE in this population, both at the 5 milligram dose and 10 milligram dose, really are pretty low. And there doesn't seem to be any kind of deep change in risk, regardless of whether or not you're on the 5 or the 10 milligram dose. So maybe in the broader population, we're not seeing that risk. Oh. Let's see, what did you do last time? There we go. In ulcerative colitis, our follow-up with this, because it's only been approved more recently, is shorter, so only 4.5 years. But again, there was no identifiable risk for DVT or PE in the ulcerative colitis population on this 10 milligram BID dosing. But because of this black box warning that's come out, in patients that we induce in ulcerative colitis on 10 BID, if they're doing well, we try to drop them to the 5 BID dose if they will stay well. And if not, then we'll try to bump them back up and have a discussion about potential risk-benefit in doing so. The other thing you see from this table is that really the rates of serious adverse events, serious infection, malignancy, major cardiovascular outcomes are not a whole lot different between placebo and tofacitinib. But the one thing that is particularly different is opportunistic infection risk. And this seems to be in a dose-dependent manner, where the higher the dose, the higher the risk of opportunistic infection. And this seems to be really driven by an increased risk of herpes zoster with people on tofacitinib. So you can see an incidence rate here of, in the 5 milligram twice a day group, of 2 up to 6 in 10 by AD. And if you look at all comers on tofacitinib, incidence rate of 4 per 100 patient years. There doesn't seem to be any change in risk. Yep. We're going to talk about that in just a second. Great question, though. There doesn't seem to be a change in risk in the longer you're on therapy. It seems to be higher in older patients, which kind of goes with zoster in general. And it seems to be higher in patients who have previously failed TNFs, and then in the Asian population, and we're not quite sure why that would be the case, but that has some risk factors that have come out. This looks to be a class effect for the JAK inhibitors, so there's a couple of other JAK inhibitors that are in development with similar incidence ratios to tofacitinib. And this is probably because the JAK-STAT pathway is important for kind of in the immune response to herpes zoster, and so by inhibiting that, you're allowing this to be reactivated. Also importantly, the risk with tofacitinib seems to be higher than with other immune suppressive drugs. So we know that opportunistic infections are higher if you're on a biologic or an immunomodulator to treat your IBD, but this seems to be above and beyond even that risk. So what do we do about this? Getting to your question. Well, the Zostavax, the old one, which is a live virus, is contraindicated in immunosuppressed patients. And in fact, if you've have been or are going to be immunosuppressed within 3 months of getting the vaccine, it's contraindicated, which is essentially all of our patients. If you're getting started on Xeljanz, you're sick enough that I can't wait 3 months to vaccinate you. We know that the Shingrix vaccine is a non-live vaccine. It's safe and effective in older patients. It is recommended for older patients who are on low-dose immune suppression, but there's really no data about whether we can give this to younger patients or whether we can give this on patients on full-dose immunosuppression. With that said, and lacking data, my practice is that I vaccinate all of these people with the Shingrix vaccine if you're going to get put on Xeljanz. And in fact, I would vaccinate all of my IBD patients on any immunosuppression, but I think we have a stronger case with the tofacitinib because of that zoster risk. The other thing that Xeljanz does is seems to increase lipids. So there's an increase both cholesterol, total cholesterol, LDL, and HDL. It seems to go, yep. Yep. It doesn't, a small fraction are the disseminated type. Most of them are a single dermatome. Yeah. Nope. Have you had any trouble with coverage in people less than 50? I haven't yet. It's more actually finding the vaccine to give than it is coverage. I think, again, with the tofacitinib risk, we have kind of some ammo to go back with to get coverage. For other patients, it might be an issue. This lipid increased risk seems to go up in the first 1 to 3 months and then seems to stabilize. And you can see here, within the first 3 months after starting tofacitinib, an increase in, with both doses, 5 and 10 of LDL and HDL above placebo, which seems to stabilize. Importantly, this is reversible if you stop tofacitinib. So this is from a trial in ulcerative colitis where everybody got tofacitinib up front, and after 8 weeks, they were randomized to continue or go to placebo, and you can see this lipid levels drop. And then you can also co-treat them with a statin. This is a trial looking at adding in atorvastatin on patients on tofacitinib and see a decrease in their total cholesterol and LDL. So we can treat it. And this is one of the things that we might be sending your patients to you to say, their lipids are up. Can you guys help us know what the right strategy is to help treat this? Importantly, we don't really know if this increase in lipids from tofacitinib changes cardiovascular outcomes. And so this is from a study looking at major adverse cardiovascular outcomes over here, placebo on the far left, and then 5, 10, and then all tofacitinib doses at an early time point within the first couple of years, and then a longer time point after multiple years. And you can really see there's no difference in these outcomes between groups. And then if you look at individual outcomes, cardiovascular mortality, non-fatal MIs, cerebrovascular events, these rates are all low, and they don't seem to be dramatically different than placebo. So whether this confers an actual risk, cardiovascular risk, remains to be seen. So just to kind of summarize on the tofacitinib standpoint, this is an oral route of administration, which patients like. It's effective and quick acting when it does work. There is an increased risk of zoster, so they should be vaccinated with Shingrix. Increased risk of lipids, which is unclear for whether or not that has a long-term risk associated with it. And then this FDA black box warning about PE and death, which we just need to talk to our patients, and we try to dose reduce them if we can. So moving on to our other new medication, Ustekinumab or Stelara, the anti-IL-12/23 biologic. This is the Crohn's data looking at both again, 2 induction trials and 1 maintenance trial. This is an IV induction, first dose, and then everything else is sub-Q, and importantly, that's different than psoriasis, which is all subcutaneous, and the dosing frequency is a little bit different. But you can see that here in the middle is our kind of run-of-the-mill patients that have failed standard therapies who need a new biologic. Response or remission rates up in the 40 to 50%. Patients that have failed anti-TNF, so this is a more refractory group. Again, response or remission rates in the 20 to 40% range. And then we see rates that remain in the 50 to 60% range out to 1 year in the maintenance trial. So it does seem to be effective in Crohn's. Similar story in ulcerative colitis, where rates of induction remission at 8 weeks are about 15%, with 61% response, meaning they're not fully in remission, but they're feeling better. And then rates of remission at 45% or so at a year. The safety data on this particular medication is not as robust because it's just been more recently approved. We have 2 years of safety data in Crohn's disease. And long story short is the rates of serious adverse events and infection don't just seem to be dramatically different from placebo. So it does seem to be safe. And I would actually put this in one of our safer biologic categories. If we're thinking about somebody who's got a higher risk of infection, who's got malignancy or something that we're trying to co-treat with, this would be one that I would kind of move towards. So just as a summary with that one, IV induction with sub-Q maintenance every 8 weeks. It does seem to be effective in anti-TNF non-responders, which is a big plus for our patients, and then a favorable risk profile compared to other biologics, and certainly compared to Xeljanz, which we talked about at the beginning. Yeah?
Are you doing that IV induction in the clinic, in the infusion center, in hospitalizing patients?
It's in the infusion center. We like to give, this goes across the board for all of our biologics that are at least IV induction, to do at least the first dose in an infusion center where it's a controlled environment. And if they were to have an adverse reaction, you would have what you need there to deal with it.
You mentioned that your first biologic is the golden one, and with the JAK inhibitor, if you go down on the dose from 10 to 5 and they flare, you get less of a response when you go back to 10, or?
We don't have data on what happens in that particular group. I think one of the nice things about the JAK inhibitors is because it's a small molecule and not a biologic, you don't have the same risk of immunogenicity or antibodies against the drug, which is what we see in biologics. So we feel a lot more comfortable playing with the dose, dropping the dose, stopping it. Also, the other thing is the half-life of that medicine is like 48 hours, unlike Remicade, where once you get the dose, it's in your system for like 8 to 12 weeks. So we can stop it and restart it pretty rapidly. I'm not going to talk about costs. All of these medicines are insanely expensive and need insurance coverage. And that's certainly, I think, as our there's a shifting environment and how things get paid for in healthcare, it's something we need to be cognizant of. The Xeljanz is only approved for patients that have failed anti-TNFs. And the reason is because of all this other safety issues that come along with it. We want to make sure that you've kind of failed a more standard therapy before we treat you with that. This is the other one that kind of comes up a lot is FMT, fecal transplant for IBD, and patients just like want this so badly. It's amazing. And so just a quick update, I guess it does make sense that fecal transplants might have a role in inflammatory bowel disease. And this is because we know that IBD patients have a unique and less diverse microbial gut flora than controls. And so this is a PCA plot where you can see that patients with ulcerative colitis and Crohn's disease, their microbiota clearly are different than your healthy controls. They clearly have a different makeup. And there are also some evidence that actually trying to target that as a therapeutic intervention has some benefit. So for Crohn's and ulcerative colitis, if you have severe colitis, we can divert the fecal stream, giving a diverting ileostomy, and by doing so, quiet down the colitis, at least for a period of time. Antibiotics can be helpful in some patients, perianal Crohn's disease and pouchitis. And then there's a questionable benefit of probiotics in mild ulcerative colitis. So some rationale to use this. I'm not going to go through this particular slide in much detail. These are the 4 different randomized controlled trials looking at FMT specifically for ulcerative colitis. But one thing the things I did want to bring out is to note that, one, the trials are all pretty small. If you think about the Stelara and Tofacitinib trials I just showed, they had 500 patients in each arm. Here we have 75 patients total. Duration is anywhere from 6 to 12 weeks. They were given, the routes of administration were different, nasoduodenal tube placement and given it by an upper versus an enema versus colonoscopy and enema. How often are you giving the enemas? 5 every day of the week except for 2 versus just 2 enemas and then follow and see what happens. The way they prep the stool is different, whether or not it was a single donor or a pooled donor. So lots of differences in these trials. But at the end of the day, the rates of remission were fairly similar across the groups of about 30% remission rates in this mild to moderate ulcerative colitis, except for this one, which did have the same remission rate, but with a placebo rate of 20%, so it didn't meet statistical significance. This is a meta-analysis looking at those same trials, and you can see here that this meta-analysis favors FMT as a treatment for ulcerative colitis to be effective, with pooled remission rates of about 30%, response rates of about 50%, and endoscopic remission, so objective evaluation of 15%. Yep. Yeah, I have one slide on the safety piece, but we buy our stool from a place called Open Biome, which has a small subset of patients that get screened routinely for all sorts of infectious diseases. And there's all these strict requirements, and they donate the stool. Before that, we used to it would be like your partner would be the donor. We would screen them for stool infections, HIV, Hep C, those kind of things, and then call it good and do it. So, there's a lot of quality controls issues, and I'll show you a slide on that in just a minute. The Crohn's data is less robust. It says RCTs. These are actually limited to cohort studies. But again, similar, looks to be beneficial in Crohn's as well, with the caveat that the evidence is lower quality. In all of these randomized controlled trials, there was no clear safety signal that FMT is particularly unsafe in these patients. And limited data using FMT for C. diff does suggest that it is safe in immunocompromised patients. So we do FMTs for C. diff in our immunocompromised IBD patients without any major risks. But this was just published in the New England Journal in the last month, where 2 patients, this was as part of a clinical trial at the Mayo Clinic. There's the same donor for both of these cases. 2 patients were infected with an extended spectrum beta-lactamase producing E. coli. One of those 2 died. These were donors that were giving stool, and they were being packaged in capsules, so they're giving it by capsule. But this certainly raises the question of, is this safe? I mean, there are safety concerns, maybe things that we haven't appreciated about the safety of these that come out and have a real significant consequence. So at the end of the day, right now, FMT is not quite ready for prime time in IBD. The questions that remain are, how should we give it, enema versus nasoduodenal versus colonoscopy? How should we prep the stool? What's the dosing interval? How long is this effect going to be? Clearly, this is not what patients want is, give me a fecal transplant and I'm cured of my disease. That is not it. This is a treatment for it, and to have it be effective, you need to continue on it. And then these safety issues come up about long-term safety. Absolutely, yep.
I thought we were not too far from just basically open biomarker FMT capsules that didn't require nasogastric tube and all of that.
Yeah, so they do have capsules that are in development. Those have not been studied in IBD that I'm aware of. They've been studied more in C. diff. And the issue is, which patients don't appreciate, is you have to swallow like 25 capsules. I mean, you got to get the same volume of stool in. So it's not like one pill that you take, it's 25 pills. And so you can imagine if you had to do that regularly, I mean, maybe patients would be more for that, I don't know. But to do that long-term in IBD might be a little bit more difficult. But yes, that is available. And then going back to C. diff, all these different routes of administration, the capsules, the colonoscopy, have very similar efficacies. Colonoscopy seems to be the highest efficacy, around 95%, but you're not losing, you maybe lose 3 to 5% in changing to one of these other routes. And so if, in the hospital, if patients are too sick to get a colonoscopy, we can just give it by enema, or, there's lots of other ways that we can give it. Great question. Yeah, so the question was, if an IBD patient, because antibiotics can change the gut flora, if an IBD patient needs antibiotics for some other reason, should their IBD status come into consideration about either starting antibiotics or what you would choose? I guess broadly, I would say no. If they have a reason that they need antibiotics, then you should use the antibiotics that are needed. I think it just gets back to kind of the mantra of only use antibiotics when absolutely needed and, for the shortest period of time possible. There's been a number of old studies looking at antibiotics to treat IBD, and it doesn't seem to be a particularly effective mechanism to treat IBD in the long run. It can trigger a flare because it can put you at risk for C. diff, not probably in and of itself trigger a flare. But it certainly these patients are already at higher, I have a slide on this later, but these patients are already at higher risk of C. diff, and so we're just increasing that risk even further. Any other questions before I move on to a different topic? I told you it was a smattering, so I apologize about kind of jumping all over the place. Great. So I wanted to talk a little bit about dysplasia in IBD, because I think this is a place where our field, the IBD field, is moving. There's a lot of talk about how to best manage this. I think in previously, patients, if you had dysplasia, your kind of route to colectomy was significantly abbreviated, and we were shuttling you towards the surgeons. You got to get your colon out, and that is not really the case these days. So we're moving a lot more towards endoscopic management of these patients. So we know that in IBD, there's an increased risk of dysplasia and ulcerative colitis and Crohn's colitis. And if you look out to about 20 years, there's about a twofold risk of colon cancer higher in Crohn's or ulcerative colitis than the normal population. And if you look at our PSC IBD population, that risk is even dramatically increased. So here at 20 years, you can see our ulcerative colitis risk about 5% or so, and up to a 30% risk in our PSC patients. So dramatically higher risk, and we don't really understand that, and we're trying to understand that. There's a number of different factors that play into how high your risk is. At baseline, just because you have IBD, your risk is higher. And I always tell patients, I can't make it go back to normal, but there are some things we can do to try to help mitigate that risk as best we can. We know that more extensive colitis, so pancolitis as opposed to proctitis, increases your risk. Longer disease duration. I already showed you that if you have PSC along with your IBD, that risk is dramatically increased. even if you just have a family history of colon cancer, whether or not that family member had ulcerative colitis or Crohn's or not, increases your risk 2 to 3-fold, particularly if they're younger family members, and that goes with our kind of general population as well. Histologic factors, so the severity of the inflammation, long-standing, very severe disease increases your risk further. And then anatomic factors like strictures and pseudopolyps and a foreshortened colon, which also are just markers of bad disease that's been there for a long time. So I tell patients, I can't make it go to 0, but we can treat your colitis as aggressively as we can to get rid of the inflammation and do it as quickly as possible to help mitigate that risk as much as we possibly can. So when should we be thinking about getting a colonoscopy in these patients? And Brandon and I were talking briefly about these patients that you guys see in clinic that have a diagnosis of IBD who come in and they haven't seen a GI doc in 5 years, and kind of what do you do with those patients? And here's an opportunity to kind of think about what at least part of the things we should be doing. So an extensive colitis, or really anybody with colitis past the rectum, after 8 years of disease, their risk, that's when their risk really starts to increase above baseline. And so they should start getting colonoscopies, and then every 1 to usually 2 years after that surveillance exam, whether or not they have active IBD or not. For our PSC patients, once they have a diagnosis of both PSC and IBD, they start getting annual surveillance because of that increased risk. So these are young patients who are coming in every single year for a colonoscopy. They don't love doing it, and we try to stress the importance of their risk and mitigating that if we can. So if you have these patients that are coming in from kind of lost to follow-up, this is certainly something to be thinking about. Is it time for them to get a dysplasia surveillance colonoscopy? In 2015, a group of experts got together and talked about what are kind of the expert recommendations, best practices that we can be making for how we should be surveying for dysplasia and IBD. And there's a lot of things that came out of this. It's called the SCENIC consensus statement. But one of the important things that did come out of this is the recommendation for chromo endoscopy to help in IBD dysplasia surveillance. So what is chromo endoscopy? Yeah.
You mentioned waiting 8 years after the diagnosis.
Yep.
Is IBD ever like a type of diabetes where it's been present for 8 to 10 years before you have the diagnosis, or at the time of diagnosis, it's probably generally present 6 months, but you can wait 8 years?
Yeah, usually when it happens, they're symptomatic enough that you're diagnosing it within a year or 2. But whenever I'm taking a history in IBD patients, I usually am asking them, if I get a sense that their symptoms have been the same and stuttering for 10 years, then I'm probably going to make kind of push their diagnosis back a decade or 5 years. So a great question, yeah. But most of the time, we kind of mark it as the time they truly got diagnosed. So the question here is, what is chromo endoscopy? So this is where we use a dilute form of a blue dye. The two that we use are indigo carmine or methylene blue. And we use a spray catheter, or sometimes we mix it in with our spray water in the colonoscopy and just spray it onto the colon. It sounds way more advanced than it actually is. But the rationale here is that this enhances the mucosal topography. It highlights the surface pit pattern. And so you can't really see this lesion that's hiding right here very well in this white light endoscopy picture, but it very clearly comes out in the chromo endoscopy side. So this can really help kind of highlight abnormal tissue. And because these patients can have subtle lesions and they're at higher risk, the thought is that this can help increase our yield. And going back to that SCENIC consensus statement, their recommendation was based mostly on using chromo endoscopy in addition to standard definition white light colonoscopy. And very clearly, if you add chromo to standard definition colonoscopy, it enhances your ability to see dysplasia. There's no doubt about it. But we don't have a ton or as much data on what about high definition colonoscopy. So we now have high definition scopes, which have much better visualization. You can see kind of standard def versus high def. The resolution that you get here is remarkably better than here. If we add chromo to this, are we going to actually increase our yield? And the answer is that's not quite so clear. We may be seeing enough now that we don't need to add chromo. So who would we use chromo in? Well, if a patient has a history of invisible dysplasia, meaning I was taking random biopsies and the pathologist, and I didn't see a lesion, I just happened to take a biopsy and the pathologist came back and said there was dysplasia there, I would go back in and use chromo in that segment to say, can I actually see a lesion that I can try to remove endoscopically? Prior history of dysplasia, that's a higher risk patient, we would use it. And then our PSC patients, again, a higher risk patient, use this to enhance our ability to see abnormal tissue. Otherwise, you're getting just high definition. And importantly, we're using high def at University of Colorado on all of our patients. And yep.
So we don't have to order the chromo endoscopy, the GI doc.
Correct. We'll make a decision based on their history. Yep. It adds a lot of time to the procedure, so we can't do it on everybody, even from just a practicality standpoint. So then what do you do with dysplasia once you find it? So invisible dysplasia, as I was mentioning, just on a random biopsy, we're going to go back with chromo, and if it's low grade, and see if we can find the lesion to resect. And then we may just, even if we don't, we may just survey them very closely every 6 months to see if something pops up. If it's invisible and it's high grade, that's ominous. That means that there's something bad hiding in there that we can't see, and they should go to colectomy. But I think the kind of really where we're changing gears is this visible low-grade dysplasia. So whether it's low-grade or high-grade, if you can see it and it's endoscopically resectable, then we're resecting it endoscopically. If it's not endoscopically resectable, then we'll send them for colectomy. So what does it mean, endoscopically resectable? So these two pictures on the left are unresectable lesions. You can see that there's kind of indistinct borders. You can tell this is abnormal, but where does it start? Where does it stop? Where do I start cutting and where do I stop cutting? Whereas these ones on the right, there's very clearly defined borders that we can go in and resect endoscopically. Importantly, let's see if this works. We have somebody at University of Colorado, Dr. Hazem Hamad, who is doing some really neat stuff with colonoscopy. So here we have a 3-centimeter lesion in a patient. He's doing something called endoscopic submucosal dissection, where he's going to mark this lesion with these little spots kind of around the entire perimeter to know where he's looking, where he's going to work. He then injects saline into the submucosa, and the idea behind here is to lift off the mucosa from the submucosal layer to give yourself a plane to try to resect this lesion. He then uses cautery to make an incision along this plane around the entire circumference of this 3-centimeter lesion. And he's done this with 6-centimeter, I mean, he's like a magician, just enormous lesions. You can see that because of long-standing colitis, they get this submucosal fibrosis, so it gets hard to resect these, and this technique is really helpful in dissecting and without perforating. He then just slowly kind of peels along this plane, peels back the mucosa to try to resect this lesion. Painstakingly, it takes hours to do this. And I just want to, wish I could speed it up, but. It's a great question. I imagine he probably quotes like a 5% risk. But the flip side is you're going to go to colectomy for this type of lesion if it's big enough that he's having to do this. Yeah, usually they're under anesthesia, just mostly not because this is painful, but because it just takes so long. He then actually uses a clip to clip one edge of this and fold the whole thing back to help him continue to peel it. And that's the lesion that you can see at the end. So, I mean, this is just a really remarkable technique, and I think speaks to the fact that we're really kind of pushing the envelope here at university about what is now considered endoscopically resectable versus unresectable. Colectomy. We don't with these particular patients, but I think that the nice thing about this particular technique is that you get it out en bloc, right? So you can tell that the entire margins are negative, as opposed to in other scenarios we have large polyps where we take off piecemeal, a piece at a time, but you don't know where the edges actually were. So this gives us at least the comfort to know that whatever the lesion was we were trying to resect then has been resected in full.
Seems like it's almost like a Mohs of the colon.
Yeah. Yeah. The reality is there's only a few places in the country that are doing these types of procedures. And so I think we're unique to have him. And he's, he's not I think importantly, he's not a cavalier kind of person. He counsels patients very carefully, and he's not going to take a case that he thinks he's not going to have a good success at getting out. So, but even, that's a dramatic case, but even with smaller lesions now, if I can clearly see the borders, I'm just going to snare it, and then I'm going to bring the patient back and follow them closely every 6 to 12 months until I prove that you don't have dysplasia anymore, and then we'll space it back out to every 1 to 2 years. So any questions about that before I move on to the last topic here? Great. The last topic I wanted to broach on was, are my symptoms from IBD or not? And I think this is a tough thing both for PCPs as well as IBD providers. Should I be changing your IBD therapy or blasting with steroids, or is there something else going on and me changing therapies is not going to be effective? And this kind of idea came out of some studies where we use disease activity assessments this is mostly from a research perspective, to assess how severe patients' disease are. And there's different ones for both Crohn's and ulcerative colitis, but what you can see from these disease activity assessments is that they rely very heavily on symptoms as opposed to objective markers. So how many stools are you having? How much abdominal pain are you having? Are you taking antidiarrheals? And this kind of helps us know, are you mild, moderate to severe, puts you in a category. And there was a kind of sub-study in 2 of our most pivotal trials. The ACCENT 1 was the trial that got Remicade approved for moderate to severe Crohn's disease, and the SCENIC trial is a trial that looked at Remicade plus azathioprine for moderate to severe Crohn's. And to get into these trials, you had to have moderate to severe disease, which is based on these clinical indices. And they actually didn't do scopes on everybody at baseline, but on the sub-proportion they did, and they found that 18% of patients that had moderate to severe Crohn's actually didn't have any active Crohn's when they looked by scope, which is a problem when you're designing a study to see if a drug's going to work. And this is kind of looking at these disease activity indices and how their correlation with endoscopic disease activity. And what you can see is that with objective biomarkers, CRP, calpro, lactoferrin, there's a moderate association with activity when we look by scope, whereas with the disease activity indices, symptoms, it's very weakly associated with endoscopic activity. So objective evaluation is imperative before we say, just because you have IBD, your symptoms are actually from IBD. And patients get really annoyed with us because we hammer this home, and they get tired of submitting stool samples. Then the question becomes, all right, well, if we're going to do objective markers to evaluate this, how do we interpret those? What markers should we be using? And the 2 that we most commonly use are fecal calprotectin. This is a cytosolic protein found in neutrophils and gets released in active inflammation in the colon. And as you guys order these, I know the normal is less than 50, but normal, quote, normal is higher in IBD patients. And so these are 2 graphs. One's ulcerative colitis, one's Crohn's disease. You can see across the bottom here, this is looking at their endoscopic severity. 0 normal in ulcerative colitis, 3 is very severe. The same is true here in Crohn's. 0 to 3 is inactive, very severe up here at the top. And then looking at calprotectin levels. And what you can see is that your calprotectin level increases as your disease severity increases, which makes sense. But importantly, if you look at what's considered remission, which is anything less than a score of 1 for ulcerative colitis, and down here, the calprotectins are in the 100 to 200, 300 range. So anything up to even 150 or 200 in a colitis patient is considered normal. Now, it may not be normal for that patient, but it shouldn't trigger us to say this is abnormal necessarily. So these are really super helpful to act as trends in patients. We know that when you flared, your calpro is 700, and now it's 100, and you were previously doing well at 100. If it's still at 100, that's probably okay. The other one we use is CRP, and importantly, this is not specific for IBD. It's increased in infections, and in particular GI infections. the other important piece, which we drive home to our fellows, is that up to 25% of Crohn's patients and 75% of ulcerative colitis patients do not ever bump their CRP. So CRP is only useful if you know for a fact that when they flare, their CRP goes up, and when they're better, their CRP comes down. If you check it on somebody you don't have that data on, it's useless. If it's normal, it's useless until you prove that they either have endoscopic activity or not. And even then, the sensitivity is only, 70%, 58% specificity, accuracy 60. So it's not the most effective biomarker even then. Yep, we try to do that, yep. And in fact, if you're flaring and I put you on Remicade and you get better, in about 6 months, I'm going to rescope you and do another calprotectin to know, one, to prove that the mucosa is healed, and two, to know, all right, here's what your calprotectin did when you got better, so that I now have that baseline. We have people that run calpros of 250 when they're not a stitch of inflammation in their gut. So it's just important to, it's important to know how to interpret these and not interpret them too rigidly, particularly in our IBD patients, and use multiple different modalities to try to understand what's going on. So what are the other etiologies of IBD for these patients? And I know we're running out of time. You guys cut me short if I need to be cut short. But the things that we need to be thinking about are infection, bile acid diarrhea, short bowel syndrome, bacterial overgrowth, and then IBS. We talked a little bit about C. diff earlier in the question of antibiotics, and this is the risk is dramatically higher in inflammatory bowel disease, 3-fold higher, and if you have colitis, it's 4-fold higher. And it comes with risk, a higher risk of colectomy, a higher risk of mortality. And we treat this aggressively with vancomycin as first and second line therapies, and then we do FMTs in these patients if need be. But we check C. diffs over and over and over and over again in these patients because they do get C. diff. Another one is bacterial overgrowth, and this is excessive bloating because of abnormal growth of bacteria in the gut. It's not dangerous, but it can be abnormal. Patients are always coming in with pictures on their phone of their bellies. I'm like, I believe you. But this is a study looking at controls versus IBD, and take home is that there's a significantly higher risk of bacterial overgrowth in IBD patients, and that probably has to do with their previous surgeries. So fibrostenosing disease, strictures, and prior bowel surgery dramatically increase your risk because you're changing the flow of stool through the gut. And we treat this with antibiotics to try to knock down the bacterial levels. A third one would be bile acid diarrhea. So if you remember, bile is made in the liver. It gets entered in the gut. 95% is absorbed in the TI. And if you get your TI resected or you have bad Crohn's of the ileum, these bile acids spill over into the gut, and you have increased permeability, increased water secretion, and they get very robust diarrhea because of that after surgery. So we treat them with bile acid binders. And then the last one is IBS. And so this is just to remind us that the Rome criteria for IBS, abdominal pain with changes in bowel movements. That sounds like an IBD patient. And turns out this is a study looking at Crohn's versus IBS, and the Crohn's disease activity index really didn't distinguish between whether you had IBS or whether you had Crohn's disease. There was a large meta-analysis of 13 studies. For time's sake, I'll just tell you that, long story short is, IBD patients seem to have a high prevalence of IBS symptoms that go along with them. And you might say, well, they have IBD and they have active inflammation, and that's going to drive these symptoms. But even if you subselect for patients that have normal calprotectins, the rate of IBS is still about 50%. So this is a big issue. And it's a big issue because these patients are more likely to come see their PCP. They're more likely to come see their GI provider. They're more likely to be on narcotics. And that, we all know there's a big push to try to minimize narcotic use in our population as a whole. So I think to treat this, the most important thing is education, education, education. It's not your IBD, it's something else. And then we do the same thing that we do for all of our other IBS patients, which is neuromodulators, antispasmodics. I know you guys are well versed in these treatments. So this is the last slide, but just because they have IBD doesn't mean that their symptoms are from IBD. If they have new or recurrent symptoms, you should restage them with initially just biomarkers and then maybe a CT or colonoscopy if need be. Make sure they don't have C. diff and do this over and over and over again because they get it. And then if there's no inflammation, look for something else. If there is inflammation, then they need to see us to get on a new therapy or optimize their therapy. And here's our group, and I'll take any questions. Thanks for your attention.
So with Crohn's disease, do you see any cases where the disease burden is most prominent in the foregut or the midgut? And if so, how would those patients then get in? How would we figure that out?
Yeah. Foregut involvement is pretty rare, and it's even rarer to be an isolated involvement. So usually those patients will also have ileal involvement. But it can be a real challenge if they have isolated jejunal or proximal disease. Usually they present more as abdominal pain, and you just have to have a super high index of suspicion, and you're going to pick it up on a CT scan. If you do have an index of suspicion that it's IBD, I recommend getting a CT enterography. I think it does a much better job of evaluating the small bowel than a regular CT scan. And absolutely they need oral contrast.
What about those like CRP or calprotectin?
Yeah, so CRP often is up in foregut disease. Calprotectin may or may not. So calprotectin is most helpful if they have colonic involvement. And so it doesn't mean it can't be elevated in small bowel disease, but you need to, just same as CRP, you have to prove to yourself that when they have active ileal disease that their calprotectin's up and it gets better if it's down. But if it's isolated small bowel disease, the calpro is less helpful. If they've had a history of dysplasia, even if I haven't found any, I'm probably going to keep them at 1. If they've had kind of a severe disease in the past and a lot of scarring, I'll probably put them at 1. They're just at higher risk.
So does dysplasia in inflammatory bowel disease arise separately from discrete polyps?
Yes, and that's been the concern all along, is that it doesn't seem to follow the same adenoma carcinoma sequence that we see in sporadic colon cancer. And often the lesions will be kind of flatter and broader lesions. And if they have it's really, the best time to do dysplasia surveillance is when they have no active inflammation, because when everything's active, it all looks abnormal, it all looks nodular. And to try to find this big 6-centimeter goomba becomes much, much harder. But yes, it seems to follow a different sequence and also a faster sequence where things can arise and progress to cancer at a much higher, faster rate than otherwise.
For the extraintestinal-like manifestations of the disease, are there specific people, like from opto or room, that you guys work with that we should be setting people to? Or
Yeah, so not with opto. Usually if they're having major eye involvement, I just want them to see who the first person they can get in to see. But for room, Christy Kuhn is really interested in kind of intraarthritis. So she also does a lot of research, so it gets hard to get people in to see her. And I think most of that group does a pretty good job, but she has a dedicated interest. The only short answer is no. And for IBS patients who have diarrhea, I tell them you can take Imodium every day, multiple times a day for infinity, and you'll be just fine, if that's what it takes to control your symptoms. So same applies for IBD patients, with the caveat being if you're using Imodium to mask their active inflammation, that has problems that go along with it. But if it's their disease is controlled, you're treating IBS on top of it, or as you're trying to get their disease under control, you're trying to just manage their symptoms, it's fine to use.
I find some of these patients, it's not just isolated to the patients with IBD, but patients who have pretty high grade immunosuppression, we're seeing for one reason or another, they've not been vaccinated against whatever we think is indicated. Do you ever think that once they're on high grade immunosuppression, well, it's too late? Or do you try to wait until they're not on high grade immunosuppression, then I'll vaccinate them to be sure? And then the other thing is, I know in solid organ transplantation, Shingrix, there's been some anxiety about it. Am I going to trigger some immune flare that's going to kill the kidney or something like that? Do you ever worry that if I give, say, Shingrix, which is a very immunogenic kind of vaccine, and I'm going to put this person into an IBD and
Yes. So to answer your first question, usually once they get on high-dose immune suppression, I'm unlikely to get, they're kind of on that trajectory, and they're not going to come off the high-dose immune suppression. Now, they may come off prednisone, and maybe that's a better time just on prednisone, or just on Remicade, not prednisone and Remicade. But if they're getting on immunosuppression, I avoid the live virus vaccines, but everything else I just give them. And there's been some data looking at pneumococcal vaccine that show kind of a marginal decrease in their ability to mount an immune response to it, but it's not low enough that that we shouldn't be giving it. We should just give it to them. The question about kind of flaring disease or having an immune response to the Shingrix, I think, is a great question. I do worry about it, and I think that the issue is how do we manage this? Again, it's not like usually these patients are sick enough that I don't have, we're just stuck between a rock and a hard place, and either you're just going to be at a dramatically higher risk of shingles, or we're going to take this whatever small risk may be there. And there's a lot of regarding this immune response. There's a lot of ongoing studies trying to sort through those pieces that I'm aware of, but we just don't have data yet. So I counsel patients that we don't really know what the data is, but I recommend it. And talking with experts across the country, they do the same. Great. Thank you, guys. I really appreciate your attention.